So Dr. Butler and myself, we do a lot of inpatients and at the medical center as well as the private hospital. And we share a few patients together, and they're complicated cases because I think there's a lot of factors involved, not just the cancer and the disease itself. And this is not an extensive list, but I just want to bring together a few cases, and many of the nurses they might recognize some of these patients, so bear with me. We had a 50 for the first case. I started with trying to get to how to approach and get the patient to kind of discuss about perhaps the goal of care. So she's a 54 years old who was diagnosed with a stage 4 adenocarcinoma of the lungs with both a lot of heavy, extensive lungs involvement as well as brain metastases, and it is a 3.3 centimeter cerebellum mass causing edema and pushing down on the fourth ventricle. She has this diagnosis for almost 6 months now and have multiple occasions declined any kind of intervention, whether it's surgical or non-surgical. And she has been repeatedly admitted to the hospital for very similar symptoms, nausea, vomiting, falls, and attempts to discuss kind of her preferences and goal of care has been fairly unsuccessful, to the point that even the ED physician felt frustrated in the whole process because it's almost like an every 2 weeks ordeal. She's going to come back to the hospital. And at one point she became very argumentative and just kind of shoo all the doctor away from her room. So it was very challenging. And she also kind of tried to cut off the family from influencing her in terms of discussing this very important issue about what to her cancer, as well as any discussion about co-status, goal of care, or essentially she would say that it's my right to come to the hospital when I'm pleases, and so don't you dare not to treat me when I come in. So it's boils out to that and become a frustrative in terms of taking care of these patients. So I would like to present her to the panel and kind of hear what each of you have to say in regard to this unfortunate patient.
Well, if I were consulting with you on this case, I'll probably start with a maneuver that I like to call the retreat to consensus. Okay, so the real challenge is we're having trouble engaging this patient in discussing goals of care, coming up with a treatment plan other than come to the ED. So, and the more direct approach is to talk about, well, let's have a goals of care discussion, or let's talk about palliative care involving palliative care. She's really demonstrated she's not ready to engage in that level of discussion yet. So it's really a matter of engaging this patient. And I might approach it as, okay, well, I'm here to be helpful to you. And so what is it that worries you the most? What is it that makes you suffer the most? Now, we're really going to help you with whatever problems that you're having. How would you rank what your problem is? And really try to get it from there, and then see what her response would be. And it might be, my biggest fear is that, I think my medical team is trying to keep you from going to the emergency room when I want to. Well, that's at least a place to start, sort of engaging her in, okay, well, let's sort of come up with ways that sort of address what make you, what makes you distressed, and what keeps you up at night. What are the things that you're really worried about? And with just trying to engage her in that way, what I would try to do is then try to get at some of these underlying things, build enough of a trust and rapport with her to get to, as soon as possible, really talking about the goals of care, coming up with a treatment plan that's not, the first and last step on the plan is go to the emergency department.
I was interested to see what open-ended question you would ask first. As I was thinking about what open-ended question I would ask first. And for me, I guess the one that kept coming back was, first of all, in terms of, it was the responding to the emotion of her anger. And all I could hear myself saying is that she's angry, saying, this must be really hard for you. I can see you're very angry. This must be really hard. it's amazing because sometimes that sounds so cheesy, but it's like, you're damn right it's hard. Like, you don't know what they're trying to do, and then it just all comes out because I didn't go in there and introduce myself as someone who doesn't want her to come to the hospital, who wants her to get chemo or not get chemo, just kind of naming that emotion where it's at. I can see you're very angry. This must be very hard for you, and kind of see where that goes. And where I'd be curious to see is based on the outpouring of emotion that came from that. I want to continue to work with you and we'll do whatever I can to help you live the best you can as long as you can. But what is your hope? What are you hoping for? And if she says, I'm hoping that my family will just leave me alone. I'm hoping that I won't die alone. So every time I get sick like this, I'm scared. So I come to the hospital because I don't want to die alone. It's amazing how things just come out with those open-ended questions. But, I think we're all aware that there's lots of good literature that you make that empathic statement and wait. And usually it's 18 seconds before we start talking again. And sometimes that just really means you're going to say that. I can see this is really hard for you. And there might be some anger, and there might be 20 seconds of silence, and there might be sobbing. And you have to be prepared to wait for that and not say, oh, I shouldn't have done this, now I'm going to leave, because that's really where it starts.
Okay. I think the thing that I want to add there is I agree, trying to ask open-ended questions to engage. But I want to go to the other extreme. The house staff often get very upset, very short-tempered. This patient is not behaving the way they should behave. They're not getting it. And some people die and they don't get it. Some people die and they never get to where we would aspire for them to get to. And I guess my observation would be there are times when we just have to play by their rule book and accept that without being angry, upset, reactive, all of those things that we have a tendency of doing when patients are not playing by our rule book. So I guess my answer would be, it sounds like this is a very avoidant patient, and there's been multiple attempts to try and engage. I don't know that I would be any better than the people who've already tried, but if it gets down to it and the patient says, no, I'm not going to do that, it's like, okay, fine, we'll see you in 2 weeks when you come back. And they come back and you deal with the problem and you let it, at some point, you accept your limitations. And when you hit that, you just don't take it personally.
So it's not fair to be last, because all the good stuff's already been said. But I think that, I think a couple things that have been said are particularly important, and that is that I like the way Dr. Sweats talked about not being a person sort of coming in with a pre-agenda with what you want from her. And what I was thinking from the very beginning was, and this probably was already attempted, but I think I would take a similar approach, but a little bit differently in that I think I would try to address, just trying to get to know her and what's given you joy and what kinds of things when you think about your life, what has been the most exciting for you, the most satisfying for you, and just try to connect with her on that level and then see where that might take us in terms of also being open with, perhaps then leading to, would you like more of this, or how can we help you get more of this, or that kind of thing. So that's kind of what I was thinking about.
Well, I think, thank you so much. All those are very, very, very helpful. I think to finish off on this, as we learn more about the patient and get her to talk a little bit more, even out of anger, we find that she's a fairly religious individual. And, well, at some point she would say that, well, Jesus will sort of take care of me. And that's kind of her belief. And I think sometimes once you get to know why she comes, where she comes from with the different answers that she gave, and her hesitant to go through any kind of therapy, and her defiant and whatnot. And I think that, as you already mentioned, to get to know the patients before kind of you can able to meet them halfway, to get engaged in their conversations. And she, at the end, she did end up enrolling hospice, and I think she was a happier person at the end, not going through the ER revolving door. So the next case, both Dr. Butler and myself also share this case. A very young gentleman, 22 years old, was recently released from jail, was brought in by family and friends because he was bleeding. Subsequently, he found to have bucket leukemia, aggressive leukemia. And his family situation is fairly unfortunate, and his, I think it was aunt or cousin, assumed the role as his mother because his actual biological mother had mental disability and also has a lot of health problems. So the cousin or an aunt, I couldn't remember, he was also assaulted when he was in jail, and he doesn't trust anyone except for her. And when we discussed about his care from the get-go and recommendations and a need to transfer to a larger center because of this aggressive leukemia, he declined, and he said that if the mother wasn't available, he will not take any treatment. And so the only way to kind of get some treatment in him is keep him locally and treat him locally. So that's kind of the initial deal that we made. He stayed for a fairly long hospitalization because of complication of the treatment. And during this period of time, initially he was very cooperative with the house staff. And then toward the tail end, he became a little bit more difficult to deal with in that he would refuse an exam by the house staff. He would not answer as to, how you feeling today, what symptoms or any kind of, so he's kind of become kind of passive aggressive, I guess, in a way. And so as soon as his count was looking better, we initially thought that because of this prolonged hospitalization, he just really fed up being in the hospital bed. And so we were able to discharge him. He spent a few weeks out, and then we readmitted him for second round of chemo. During the second readmission for further chemotherapy, he initially was very calm and collect, but soon after a few days, after getting actually the first day of chemo, the aggression came out. He became very aggressive, and at one point, he actually had 3 knives in the bag that he brought to the hospital, and was threatened to stab with those sharp objects. And it was a very impressive between the security team and the patient himself. And we got engaged, with the psychiatric specialists to kind of come and help him out. I think because of his background with the different things that's happened to him, he's younger. And so I guess we'll start with Dr. From this end forward. How would you, given that history initially, would you engage psychiatry early on? And
You want to go first?
You don't pick easy cases, do you? So, I mean, I think the TV shows that I watch related to this, like there's special units for people like this. So I would really recommend that you go there. But some of the things that I was thinking about, just very basic principles. So I'm oncology symptom management researcher. This is totally out of my league, but I do have a little bit of experience. And so I guess a couple things I was thinking was, I think it's really important as much as possible to keep the people who care for him limited so that he can develop some relationships and some trust. And I think actually perhaps maybe some sort of contract in terms of this is the care you would like, this is how you need to behave, this is how we'll behave. I think to that level with somebody like this, but yes, I would absolutely engage psych early, and that's probably all I have to say.
Psych consult would be number one. But I'm going to echo what you said. When I've had difficult patients who've had really significant past issues with incarceration, the first thing I'll tell them, particularly if they start acting out, is, I'm on your side. I'm in your corner. You don't want to alienate me. You don't want to alienate the nurses, because we're the ones who are fighting for you. Don't make us the enemy. And for good numbers of patients where I've had to take that approach, it's actually been reasonably effective to try and redraw the line with them to let them know that I'm there. But also, I think you really have to set boundaries with regards to behavior. You will not bring a gun, a knife, or anything into this clinic. If you do that again, you're out. You will not swear at my staff. That is unacceptable. If you swear at my staff, you're not welcome. And when you tell them simultaneously, we're here for you, we're gonna hang with you, but here's what we won't accept. It's amazing how the bulk of the patients who have, and I probably only had to deal with this like maybe half a dozen, 10 times in 25 years, but they kind of backed off and they didn't want you to go away. And they were like, okay, all right, I'll try and be cool. That would be, and then I would call John and see what you're going to do with this patient.
I think, the first thing I thought of is this a trick? And there's like, this is psychotherapy, neurotoxicity. Like you're giving him, and that's what this is, like neurologic side effects. Like I'm getting the sense that there's not any real cliffhanger here. Because the first thing I want to know is there something that's medically causing it? And I guess this is where I agree with everything that's been said. And, we had a situation where my colleagues and I had kind of written about managing behavioral issues in borderline patients. And I'm not particularly sure this is a borderline patient. I think he's had a lot of other life experiences that doesn't put him in there, but certainly borderline patients can act out like this. So aligned with them, but also setting firm boundaries and minimizing opportunities to split is important. Where I might be a little bit different on this, and perhaps this is part of practicing in Birmingham versus practicing in rural Minnesota, like I did for a long time, is I'm fine with partnering, I'm fine with aligning myself, but I will have no tolerance for violence or threatening my staff, because my number one obligation is to my staff. If I'm their chief, they are looking to me for guidance. So if there are family members that are threatening, I can sit there and say, oh, I'm going to have security remove this person, but it's not an acceptable situation to be somewhere where there's violence and in my short time I've had violence. I've had people shooting heroin up in their room and all these kind of things that I've heard about, SVU type, special victims unit type situations, and I think it's one of those, again, I had a patient recently die on hospice care, and it was the first one that I absolutely sat down when he told me he was selling he was giving his pills away, his opioids, for rides and things, and not taking them as instructed and diverting them. And I was very clear, this is my license, This is my livelihood. This is what I'm called to do to serve others, and I cannot allow your bad choices to impact the health care that I provide to other people. So you will not do this again, or you will not get prescriptions from me. And the fellow was like, this is the beginning of fellowship. She's looking at me going, I was like, it was like not me at all. But that patient I did a home visit on 4 months ago, and he was like, you saved my life. You did the best thing that's ever happened to me. So as tough as it sounds, and as much as, you do have to be very, very firm and have a low tolerance, unless he has intracranial bleed, inside therapy, toxicity, or something that you're like, I'm going to reverse that. But if this is just bad stuff, then the boundaries cannot be overestimated. Safety of everyone first.
John, may I say something before you speak? Just a little addendum to this situation. The relationship, I think this gentleman has a lot of abandonment and issues, because one thing that happened after this is she had to stay in our, wouldn't go to a tertiary center because the mother had to be near him. After that decision was made, the mother basically disappeared and would put, in fact, I think this admission, when this happened, he had missed his admission for his chemotherapy because his mother had taken off to Florida or something. He didn't get in the hospital and had to delay to the next week. So I would imagine the message he's getting in this dysfunctional family situation is, your health really doesn't matter. And I think I would have a little anger issues with that too.
Well, I guess the first thing I would say is that you all keep your psychiatry consult service very busy, apparently. And unlike Dr. Murphy, I've seen this case a few more than 10 times in my career. And again, I agree with, and would echo everything that's been said. I mean, you want to make sure that this was not some acute, if it were an acute change of behavior, it wasn't a pattern of behavior. You can infer from the history of run-ins with the law and other things that this is probably not an acute change from behavior, but if it were, then you'd look for a delirium for whatever reason. That's someone who's as ill as this young man is, that's clearly where you'd start. Other thing to know is safety is paramount. I mean, you really can't, as much as our empathy and our hearts go out to this young man, if he's really bringing weapons into the care environment, you just can't tolerate that. But then you really do a clear diagnosis. And there are other things besides delirium that this might be. Certainly substance abuse is a high probability. Is he bringing contraband substances into the hospital environment, and is he sort of intoxicated and causing this change in behavior? But let's assume that it's more in the personality disorder realm, which is sort of the first thing that I would think of here with what we have with this story. And it really depends on what type of personality disorder you sort of, how the approach you would take. If this is someone who had more of a paranoid personality disorder, then what you would do is to be very professional and non-threatening. He's having trouble trusting folks. If you go in and are too chummy or too aggressive, then you're really going to lose all chance of an alliance with him. If it is more of a borderline personality disorder, then it's really like parenting an 18-month-old. You really got to go in and have lots of structure and lots of boundaries. If this is someone who has an antisocial personality disorder, then the sort of approach of here's what's in it for you. I think Barbara talked really nicely, had a very elegant way of describing that. We're on your side. Don't alienate us. And folks who have that sort of antisocial personality disorder, that's something that's going to resonate with them. Here's what's in it. So let me put it in terms of what's in it for me. Okay, thank you, Doc, I can get that. And they may also do a little bit better with, if you got to be careful with this, the sort of interpersonal style of basically a drinking buddy. It's the kind of folks that they bond with. If you guess wrong and you go in with sort of, hey, how are you going to look? I'm on your side, I'm your pal. Every time you do this, the nurses bust my chops, so, give me a break. You go in like that, and if somebody's paranoid, they absolutely don't trust you at all. So you got to be, I think the way that Barbara framed it was very elegant and doesn't run the risk of that kind of, because it's professional, but communicates that same message. The other thing to say is, if in folks with this, who've got this sort of personality structure, assuming that's what it is, then they just haven't developed those mature coping mechanisms to use day to day, even when things are going well and they're medically healthy. All of us, when we get sick, regress. That's part of the deal of being a patient, right? I mean, if I get sick enough to come into your hospital, you expect me to stay in my hospital bed and let other people bring me my food and not go to work, and do things and be babied a little bit. When I get a head cold and I expect my wife to take care of me like that, she gets annoyed. But if I'm sick enough to be in the hospital, then you sort of expect me to, and psychologically, the patient role is regressive. I'm regressing to a little more dependent, almost childlike behavior in some ways. I've got somebody coming in and caring for me. If you're already starting from a not very mature place, and you regress from there, then you get these kinds of behaviors. And so the approach is really like parenting a small child whose behavior is having a tantrum. You don't get sucked into the drama. If you sort of escalate, it's like dealing with a 2-year-old temper tantrum. When my kids would do that, rather than yell back at them, which is what they want, then they're completely in control. What I would say is, look, Dad's a psychiatrist, and he's not very impressed. You need to take that up to your bedroom because I don't want to see it, but I'm not impressed with it.
Does that work with preteens?
Yeah, sometimes it works like magic with 2-year-olds. Temper tantrums melted away when they realized you weren't going to get sucked into the drama. So you have to maintain a professional stance. We're here to help you. We want to help take care of you. For us to take care of you, you obviously cannot bring knives to the hospital. You obviously can't threaten our staff. I mean, that is a deal breaker. But we want to take care of you, and use this. It's the same kind of techniques you would use parenting a small child.
Let me ask I want your comment on 2 things. Number one, I would wonder whether this young man was abused, if not physically, at least emotionally. It sounds like what we're hearing, that may be the case, and how you deal with that aspect. And then the second aspect is imprisonment, and what imprisonment does to behavior patterns and the expectation of what's normative behavior in a prison is not normative behavior out in general society, and transitioning from one to another, especially if you've never had a normal childhood, means that you really don't know, have a sense of what normal behavior is, or you don't have acceptable coping. Can you just comment on that? Because I would love to hear what your thoughts are.
Okay, so the first point was abuse. Okay. Physical and sexual abuse, especially when it happens to young children, and it is shockingly common. We talked about sort of all the different spectrum of post-traumatic stress. I think of your diagram, all the irritable bowel syndrome, and post-traumatic stress disorder, and fibromyalgia, and all of these things. And one of the final common pathways may well be things that prime and overstimulate the central nervous system. And so the kinds of traumas that can cause PTSD are the kinds of things that really make you feel completely out of control and put your life at risk. So whether it is being sexually abused, raped, living through a hurricane, a house fire, any number of things that can happen, especially if they happen repeatedly. And that's where childhood abuse and childhood sexual abuse is especially toxic. I mean, if you live in this part of the country and you've lived here long enough, you probably lived through a hurricane or two. And you may have had an experience yourself, or have other people who've had an experience of nearly losing your life, or someone you love nearly losing their life. But that only happens every once in a while. If you're sexually abused as a child, while your brain is maturing and while your psychological makeup is forming, then you're having this experience repeatedly. Then it really doesn't, we don't have to explain too much more to understand that can really cause lots of difficulties with not only trust issues and abandonment issues, but also sort of moving your brain to this state of red alert that you're stuck in all the time. For jail, I mean, the way that you basically survive in jail and prison is that you've got to be the biggest badass on the block. I mean, you really got to establish that you're not to be messed with. And so, depending on how much time this young man has spent in jail, when under stress, when feeling threatened, then that may be what he reverts to. Look, I've got to make sure that when I'm feeling out of control, I have to assert control or I'm in big trouble. That's a very primitive way of solving that problem, rather than saying, hey doc, I'm really scared. Can somebody talk to me about how scared I am? But that may actually be, regressing to the kind of behavior that you often have to use and have to use in the setting of being in prison. Is that helpful?
I think that's fabulous. And the only thing I would add is there really is, I'm into brains today, I don't know why. Mine isn't functioning very well because I'm tired, but really those kind of stressors do permanently alter brain
Absolutely.
anatomy, function, and we as society have to get that when we don't take care of our children well, even in utero, that we pay the long-term consequences as a society with regards to health and behavior. And so, I kind of look at somebody like this and go, Mom abandoned him. Well, was Mom there ever? The little monkey experiments where they had what's the classic one where there's the monkey that's the cage, or that's just the wire, and then the fake monkey that is covered with something nice and warm and fuzzy.
Yes.
And the food was the one with the wire, and they'd go run to the monkey with the food, eat, and then run to the one that was a fuzzy warm mom.
Right.
Underscoring that and the need to have that warmth in order to be able to grow emotionally normally. And I think of that was, gosh, that's probably 30 years ago, 40 years ago when I remember hearing about that experiment. But I think of this kid when I think of that experiment when I think of this kid and knowing that his mom abandoned him. What happened all of his life? What happened?
One last comment that sort of echoes Keith's sort of opening gamut about, that sounds like it's very difficult, and then waiting for the response. If you sort of intuit that some of this has to do with abandonment issues and control issues, irrespective of I have to behave like I am in jail. I've had several cases of usually young men who had childhood illnesses and really ineffective parents and caregivers. And so they would often reject care, and it really got to the point where it was really a way of asserting control. Young man with a congenital immune deficiency that I recall seeing, who had another episode of fever, and as part of the workup needed a spinal tap and was refusing the spinal tap, even though the kid was an expert on congenital immune deficiency. He knew the indication, he knew the risk that this could be a bacterial meningitis, and he knew the risk of delay. The kid could have given a lecture on his condition. But what happened was the intern was rude. The intern was belittling, and when she came in to see him, he absolutely said, "No, I'm not going to take that treatment." In fact, he's trying to sign an AMA. Figured out that the problem was really this was a control struggle. When you're really engaging in a control struggle like this, you're not going to win. So you retreat to consensus. Okay, look, I'm not going to fight this battle with you. What I decided to do is I said, look, and it's a similar kind of approach here. What doctors and nurses do is we recommend patients decide. So you get to make this decision. So you're in control. We're going to make recommendations to you, but you get to make this decision. You're completely in control of this. All these doctors looking after you aren't. And then I said, okay, well, let's think this through. Here's the logic for choosing to have this spinal tap. And here's what might happen if you don't. Your choice, he said, I choose to have a spinal tap. I said, great. He said, but not by that bitch intern. I said, understood. So we got somebody else to do the spinal tap. He got the spinal tap. And so oftentimes, another kid with really because of his life experience, really kind of immature coping mechanisms. So that's the sort of psychiatric bottom line. You got to figure out what's kind of going on here psychologically, craft something that fits that, but you can't let folks bring knives on the war.
So I have a third case. Didn't put it on the list. She's 75 years old. She had tonsillar cancer, was treated with concurrent chemo radiation about 10 years ago. And so when I initially received her care transfer from another physician, she came in with essentially weight loss, and upon finding what's been going on, and she had to have the most severe oral, dental, gum necrosis that you could ever had. And literally, if you take a look inside her mouth, her teeth is on the verge of crumbling and just falling into little tiny pieces. On top of that, she has Zenko and would refuse having anybody do a scope down. And she had one time done it at UAB 6 or 7 years ago, and that was the last time she would allow anybody to have it done. So it's really affected not her nutrition and her weight gain. Maintaining a healthy weight, she's only weighed around 86 pounds, hovering around 86, 88 pounds. But also her social life. She doesn't go out with anyone because she says, I have to puree all the food. It takes me hours to get all these down. I don't go out. It's just debilitating. So we kind of got her to an oral dental and kind of take a look at the whole situation. She does have radiation-induced necrosis and whatnot. And the recommendation was two-step, to initially go through hyperbaric treatment, oxygen first, and then followed by, reconstruction and whatnot. She thought about it, initially thought that she might go through the whole treatment and then kind of change her mind and say, no, I think even though as debilitating as this is, I'm not going to go through that because I don't know what the outcome, it could be worse than what I have now. So that's we kind of stuck in this nebulous land of, and she's continued, start losing a little bit, a few pounds slowly. You have any thoughts, Dr. Murphy, or anyone on the panel?
So this is one of the reasons why I'm known as a nag among my patients. I nag them to sit up straight. I nag them to do their swallow exercises. You know this. I nag them to to do their stretches. Yes, sit up right. Yeah, in my clinic you sit up straight. Otherwise you don't walk in the door, which is really setting boundaries. And this is why, because if patients don't take care of their teeth long term, one of the problems becomes they get radiation dental caries, and this is 7 and 8 years out, right? So you're out of ways. And radiation dental caries one of the worst complications is osteoradionecrosis. And the rate for osteoradionecrosis in most series is going to be somewhere around 8%. So 8% of head and neck cancer patients will develop ORN. Now, that doesn't mean it's ORN that becomes severe. I mean, that may be exposed bone that will eventually, you'll get mucosalization down the pike. But this is what you're most worried about with ORN. You have a lesion that's significant. Your big question is it something that you can actually fix with hyperbaric oxygen therapy? And if it's really bad, they're going to need reconstructive surgery. So then the question becomes, should you use hyperbaric oxygen before your reconstruction? And there's no real data on that. We tend to use hyperbaric oxygen before surgery. They'll go into surgery, have the reconstruction, have all of the rest of the teeth removed at the same time, and then subsequently get dentures. What I tell patients in that situation is when they have a mouth that is filled with ORN, they feel like crap because this is a tremendously inflammatory process. So they don't feel well, they have pain, they can't eat, they can't go out. There is not a component of their existence that is not adversely impacted. Mandibular resection for ORN actually is not associated with on a scale of 1 to 10, realizing that my perception of what's tough surgery and not is highly skewed by the fact that all of my patients are head and neck cancer patients. But this is not surgery that's really, really rough. I mean, you know, you're not doing a total glossectomy. You're going in and resecting a section of the mandible. And I can't even think of a patient that I've had that has gone to mandibular resection whose outcomes have been worse. Can't think of a one. So if I had a patient who was very concerned that, oh my gosh, my life is going to be worse, I'd hook them up with one of the patients who went through this and say, all right, I hear what you're saying. These are the things that I think we can make better. Let me let you talk to somebody who's been through it, because there's nothing better for a patient who is scared about a procedure than to talk to a patient who's been through it so they can help alleviate some of their concerns. But I also walk them through, if we don't do this now, here's where we're going to be a year and 2 and 3 years from now, because it's going to be worse. I mean, this is not a problem that's spontaneously going to go away. It's not going to get better. We're going to be here eventually. Let's get it taken care of now before the problems are compounded. And I would just be really forceful in my, and you know I can be very forceful, but I would be very forceful with my recommendations that we really don't have a choice but to solve this problem.
I thought of 2 groups of cases as I heard this. The first is for those that were here yesterday. One group that I take care of quite frequently is advanced heart failure with left ventricular assist devices. And one of the most challenging situations with that particular group is the risks of complications that can come. And often, I think one of the reasons I got inserted into working with this particular population is because those particular patients felt as though they were told, well, you can get a VAD or you can die, what would you like to do? Right? And that's a tough situation. The cardiologists don't like to be in that situation. And I think that's really where, we have to, they're looking for guidance, and I think the way Dr. Murphy talked about giving guidance, not necessarily telling you what to do, but making a recommendation and making sure that you're there and going to not abandon them regardless of what they choose is important. That's a pretty extreme example. The patient that immediately came to my mind was a person who came in with marked weight loss and was found to have MAC complex throughout her gut. And it was just impacting, a lot of lymphadenopathy, a lot of malabsorption, a lot of abdominal pain, and a ton of weight loss. And for those of you that have treated this, 5-drug combination for 18 months, depending on how bad it is. TB is one thing, but this is, and this patient was miserable, and the drugs made her feel awful. And she didn't want to eat, and she continued to lose weight. And I remember the house staff saying, she's depressed, she just wants to kill herself, she doesn't want to live, she doesn't want to fight hard enough. Yet at the same token, it's like, yes, we have a treatable disease here, but is the treatment worse than the disease itself? And this was a really, really, really tough case because there were a lot of issues with not having family support and a lot of the things that have gone in that we've talked about already. But to say, I know that these 5 drugs can potentially treat you, but there are risks associated with it. And there was a time she just said, I'm not going to go home with drugs. I'm just going to see how it goes. And last I checked, before I moved, she had come back into the hospital and was restarted on the medications because things were kind of lingering. I think folks that used to have hepatitis C face this problem a lot. Before you had whatever the generic name of Harvoni is, I'm sorry, they're big words that I can't pronounce. When you had the choice of ribavirin interferon, and you felt like garbage for 18 months. Yet they said we can get rid of hepatitis C and you won't get cirrhosis, and then you won't get cancer. Really tough. And I've had family members who've been treated for that who said it was awful. And the hard part is I think the patient can be very, very helpful when seeing someone who's gone through it, but I also think in a way, there was always a man who would come and show how great he was doing with his dad. And you could see someone who's doing great, but we never took patients into the rooms to show the person who had the stroke and was on ECMO and ventilated and dialyzed. We always show them the patient who was in that situation. So I guess what you've heard is 5 minutes of waffling in my situation. 5 minutes of absolutely agreeing with Dr. Murphy, but at least tempering it with sometimes we just have to meet people where they're at, and we could give them the best recommendations we can. The truth is, we don't have to take the ribavirin and interferon. We don't have to take the clarithromycin and pyrazinamide and other drugs that you have to get from the third world. And we don't have to necessarily go through this procedure, but if we could partner with them, if we could be present to them, and if we could really let them feel like this is my recommendation, but I'm with you no matter what you choose, I think that's the most important piece.
I think you have to also distinguish the situation where you know you can fix the problem versus, and a resection of a mandible is, these days you're in and out in 3-4 days, and afterwards you can feel a heck of a lot better. So there's that, for some people there's that hump that they have to get over, that which is a little different than, okay, it's going to be 18 months in a trudge. And so I do think that there are times when I look at people's options and I sit there and go, I don't know what I would do if I were in your situation. Or versus situations where you go, this really is, this really has very little in the way of downside here. And so I feel a little bit better about really being emphatic about my recommendations when I've had that experience, and I think a patient's fear is keeping them from moving forward with something that really has a tremendous capacity to help them out. But you're right, there are the situations where you're sitting there going, wow, I don't know what I would do if I were in that situation. So in those situations, I am very neutral, very, very neutral. I'll say, here are the pros, here are the cons. I don't know what I would do. This is a decision of heart. You're going to have to feel out the right decision for you. And then you're right. No matter what a patient decides on anything, you honor their decision.
Well, thank you so much, our panel discussants. There was a very thoughtful and very helpful tips and also thoughts on way to approach some very challenging cases. I know it's late, and so I think we're going to conclude there, and then other things we can pick up at the dinner. But I also want to thank the audience for really staying this late and coming out for this year Oncology Outlook. Thank you, Dr. Butler, my co and also thank you, Susan. So.